Okay. Hello, guys. My name is Rafael Pinto. I bet most of you already know me, but those who don't, I am a medical doctor from Venezuela, and today I'm going to bring a paper that I found while working on a different systematic review. And this paper is titled "Treatment of Heavy Menstrual Bleeding of Endometrial Origin: A Randomized Control Trial of Medroxyprogesterone Acetate and Tranexamic Acid." This was a study done by Goshtasevi A in 2013, and it was conducted in Iran. So, for the purposes of this assignment, I'd like to first begin by giving a brief introduction or the rationale behind this study. Then I'll continue talking about the study design, the randomization and blinding techniques, and finish up by mentioning the outcome measurements, the results, and a few takeaway points. Okay, so first of all, an introduction or why was this study done? Like, why did the authors decide to perform this study? I bet most of you know that heavy menstrual bleeding is a common clinical problem. It affects women of reproductive age, with 5 to 10% of women seeking medical attention because of this. And it is important because it affects women's physical, psychological, sexual, and social life. So there's a rationale or there's clinical importance to this study being performed. Now, specifically about this study, there's literature that shows that both tranexamic acid and medroxyprogesterone acetate, or MPA, could control HMB. Now, what we don't know is which one of these two suggested treatments are better and which one produces less adverse effects, so that we can sort of make a clinical decision surrounding which drug is preferred for these patients. Okay, so we can see that the aim of the study was to evaluate these two drugs side by side. And since there's evidence about their effectiveness, you could say that these drugs are, or the study has clinical equipoise, because none of the two drugs have been shown to have um, a much better effect than the other. So ethically, this study is justified, or at least we could consider that this study is justified. Now, about the study design, they used it was a randomized control trial. It was a randomized parallel study design. It consisted of 90 patients from 20 to 45 years old who complained of regular HMB, and these were taken from three gynecological clinics in Iran. Some patients were excluded, like patients with organic causes of HMB, iron deficiency anemia, thromboembolic disease, and OCP use. And the study had two treatment arms. One of the treatment arms consisted of 44 patients who received medroxyprogesterone acetate and 46 patients who received tranexamic acid. Now, about the randomization, the study used a block randomization technique, and we already know how this works. Basically, you divide patients into blocks of preset size or random sizes, and then you allocate these subjects into one of the two treatments so that they're evenly distributed. So if you have blocks of 4, then you have 2 and 2. If you have 6, then you have 3 and 3, and so on. Now, the thing with this study is that there's not much indication about the size of the blocks. It doesn't really say anywhere how big these blocks were, if they were random sized or not, and there's no mentioning about the allocation concealment. So these can somewhat cause or lead to a selection bias, because you don't really know how the subjects were allocated. You don't know if the person that allocated these patients could have caused bias in the study, and there is a risk of imbalance. So this could be a potential problem in the study design. But we can see now that there's a reason why there was no allocation concealment, and it was because this was an open label study. However, there's no mentioning of the blinding status. There's no mentioning about the open label nature of the study, which I found a little surprising. However, we can see that maybe the reason behind this was that it could have been maybe there could have been logistical reasons behind it, but one possible reason was that it consisted of two very different treatments, because MPA is given 5 milligrams twice a day for 21 days from day 5 of menses, whereas tranexamic acid is given 500 milligrams every 6 hours for 5 days from day 1 of menses. So not only are these treatments given different number of times per day, but also at different times from the around the menstrual cycle. So that could have been a reason behind they doing it like this. So I believe it is an open label study while it's not explicitly stated. And we know that since there's no blinding, there's a risk of performance bias because of this. Okay, continuing on, we see that about the outcome measurements, the primary outcome was measuring menstrual blood loss. And this was done through a special chart known as a pictorial blood assessment score, or pictorial blood loss assessment chart. And this was evaluated at baseline and 1, 2, and 3 months. The thing with this is that it is a semi-objective tool. Basically, what you do here is that the patients are given this sort of chart so that they can put in what they saw in their about their menstrual blood loss. For example, if they used pads, then they can see, for example, if they had little amount of blood loss, then they only used one pad during that day, then they only do like a little mark. If they had a lot of blood loss and used several pads, then you start by putting how many pads and how much blood were in those pads. So basically, you do all this, and then at the end, you start counting how many of these pads were in each. There's a multiplier that you use so that you get a score, and at the end of the menstrual cycle, you add all these points, and then you get a total score. Basically, this is a way that some clinical authors use to measure blood loss, because it is kind of difficult to actually measure the exact amount of blood loss. There are some objective methods that you can use. For example, there's a special one called the alkaline hematine method, but this can be more expensive. It also requires the patients to save up all their menstrual pads, which can be uncomfortable for them. So some others prefer to use this method while doing clinical studies. Now the thing is this is semi-objective, is somewhat subjective, because the patients might consider, hey, I only lost some blood, or I lost a lot of blood, and that can introduce bias. There's a risk of a self-report bias, because some patients have different conceptions about why they consider more or less more or less blood. Now, that was the primary outcome, but they also measured other outcomes. For example, they were keen on evaluating what the effect of menstrual blood loss was surrounding their health status. For example, they did a heavy menstrual bleeding questionnaire, which evaluated the effects of HMB on their perceived health status. But this was a questionnaire, so there's a risk, because it is a subjective measurement, there's a risk of some sort of bias because of this. They also did this SF36 questionnaire, which is a quality of life questionnaire. It measures both physical and mental components of QOL. But this is also a soft or subjective outcome, because it is done by the patients themselves and not by a physician. Lastly, they did evaluate some laboratory values, like for example, the hemoglobin and the ferritin. They were both evaluated at baseline and after the 3rd month of treatment. And these can be considered hard or objective outcomes, which are less prone to performance bias. Okay. After evaluating all of this, we already know that 90 patients were randomized. 44 were assigned to the MPA group, and 46 were assigned to the tranexamic acid group. But what happened next was that after the first cycle, that is after the first menstrual cycle, 5 patients discontinued the MPA group, 3 because they had spotting, 2 had irregular bleeding, 5 patients discontinued from the TA group. And then afterward, after the second cycle, 6 patients left the study, One had fibrocystic changes in the MPA. We know this is a progesterone analog, so there's risk of some other systemic problems surrounding the usage of this treatment, and 5 had irregular bleeding, whereas 3 patients discontinued the TA group, 2 had vertigo, and 1 had headache. So at the end, we can see that only 33 patients completed the study in the MPA group, and only 38 patients completed the study in the TA group. So this is what I consider a high dropout rate, especially with a study that has such a small sample size, 25% in the MPA group and 18% in the TA group, mostly due to adverse effects of the drug. The authors mentioned that they performed an intention to treat analysis to deal with this, but still, there was a high number of patients that left the study or that dropped out of the study. Okay, so at the end, these are the main results of the study. We can see that both treatments were useful in reducing the PBAC score, duration of bleeding, quality of life, and hemoglobin values. You can see here, for example, before treatment, patients had around 8 days, and then after treatment, you can see it reduced 6.86, 8.06. PBAC score, like this is a very big difference. Look at this. You can see the PBAC score before the treatment was around 200, and then after treatment, it was around 100. So there was a big difference there. Also, hemoglobin and ferritin levels rise in both cases. So you can say that the treatments were effective. Now, there was no statistically significant difference between the groups. So just by the effects of both drugs, we cannot really say that either of them is better than the other. So both can be useful for the treatment of heavy menstrual bleeding. But there were more drug complications and less satisfaction reported by the MPA group. So this can be a way in which we can sort of say that maybe tranexamic acid is better than MPA. However, as I've said before, we need to consider the clinical situation of each patient because tranexamic acid is an antifibrinolytic, so there's risk of bleeding anywhere. Okay, so to end up, a few points or a few thoughts about to discuss. This study had some problems because it had no allocation concealment. This can risk or increase the risk for selection bias. So yeah, we need to take that into account. Next up, this was an open label study. There was no blinding, so there's a risk of performance bias. Next up, it had a lot of soft outcome measures, so there's a risk of detection or self-report bias as well. And lastly, it had a small sample size and high attrition rate, so there's a risk of a type 2 error. So while the study aimed to address a clinical situation that is very important, and while it seemed to have or have 2 treatment arms, about 2 treatments, and it showed effectiveness surrounding both treatments, there's a good amount or a good risk of bias surrounding all of these steps. So these results need to be taken with caution. I would say that in looking at the literature, more studies have been done to evaluate the effect of tranexamic acid, about other OCPs surrounding for the usage or for the treatment of heavy menstrual bleeding. Um, so, so yeah, I think that it was an interesting study design. It was a good clinical problem that they aim to evaluate or to assess, but probably the way in which it was conducted and the things that they didn't think of at the beginning of the study, maybe it could have led to these results not being as meaningful as they should have been. So yeah, thank you so much for the time and be cool. Thank you.